Hey guys, it's Medicosis Perfectionist, where medicine makes perfect sense. And today we'll talk about limb block, or a more accurate term would be peripheral nerve block. Because I'm not just going to talk about upper limbs and lower limbs, because you can actually block almost any peripheral nerve you want. There's even an intercostal block. And while wise people say no pain, no gain, anesthesiologists say no pain, no pain. Let's answer the question of the previous video. Who is particularly prone to aspiration syndrome? And here's the answer. Alcoholics, quadriplegics, this could be a spinal cord lesion, amyotrophic lateral sclerosis, or locked-in syndrome that you see when you have a basilar artery stroke, if I have a seizure disorder, if I am unconscious, or whenever my Glasgow coma scale drops below 8. The lower the score, the worse, because it means that I've lost it. Impaired cough reflex. If I cannot cough it out, it's gonna end up in my lungs. This is aspiration. Brain injury, of course, because if I have a brain injury, cough reflex is gone. Why? Because it's a reflex. It has to have a center inside the central nervous system. Neonates, because they are young and delicate, and the elderly population, if you're too young or too old. Notice that all of these people suffer from inability to cough it out. That's how you end up with some gastric content, GI content, any kind of content in your lungs. And it can lead to aspiration pneumonia. And if it's so bad, it can lead to atelectasis. Thanks for the lovely person in the comment section. I've made a mistake. Now it's time for me to correct myself. In the previous video, I did the opposite. I did the general anesthesia as the outer circle and analgesia as the inner circle. Not true. This is the true one. Anytime you have general anesthesia, you have analgesia. However, not every analgesia comes with general anesthesia. General anesthesia means loss of consciousness. Analgesia means loss of pain sensation. Anesthesia care, preoperative, intraoperative, postoperative. Evaluate, choose, pre-medicate, monitor, access, plan, and then control, monitor, and dispose. Anesthesia is general, regional, or local. Regional is divided into neuraxial, limb, and others. Neuraxial is in the midline. Oh, you're talking about spinal cord here. Absolutely. It could be spinal or epidural. Has to be in the midline. However, if you go to the extremities, oh, that's the limb block. That's today's topic. Neuraxial was the previous video's topic. Let's talk about limb blocks, or more generally, peripheral nerve blocks. In neuraxial block, it was midline. Yup, epidural or spinal. Epidural went to the epidural space. Spinal went to the subarachnoid space. Why did we use neuraxial blocks? Because we were performing surgery in the lower abdomen, pelvis, perineum, lower limbs, etc. What the flip were we injecting? A local anesthetic. Basically, anything that ends in cane. How about today's topic? What are we using? We are still using local anesthetic. Anything that ends in cane. How the flip do they work? Oh, I'm glad you asked. They block the sodium channels, because normally sodium channels are responsible for depolarization and activation of the neurons. If you block the sodium channels, you will not activate the neuron. The nerve is not gonna feel anything. No pain, no pain. So let's review some physiology. When potassium leaves, this is inactivation, because the positive is leaving the inside of the membrane, more negative. That's inactivation. How about if the negative, chloride, is entering? Oh, same thing. The inside of the membrane becomes more negative, hashtag inactivation. But when the sodium enters, this is activation. And this is what needs to be blocked. We have 3 types of nerve fibers, A, B, and C. Of course, A is the thickest. It's thick, it's myelinated. B, thin, still myelinated. C, thin and unmyelinated. It's neither thick nor myelinated. Which one will be most easily penetrated by the local anesthetic? Of course, the thinnest. Well, no duh. Type C fiber, because thin and unmyelinated, is going to be the first one to be affected by local anesthetic. And if you remember your neurophysiology, the pain fibers belonged to subtypes A delta and C. C fibers carry pain sensation, and they are the first one to be blocked by the local anesthetic. That's how anesthesiologists, pain doctors, and freaking dentists make their living. Moreover, the postganglionic fibers, sympathetic or parasympathetic, are also type C fibers. And that's why in the previous video, one of the side effects of spinal anesthesia or epidural anesthesia is hypotension, because you blocked the sympathetic in the lumbar area. Sympathetic is thoracolumbar, and you ended up with decreased alpha-1 stimulation, decreased vasoconstriction, which involves two things: decrease arteriolar constriction and decrease venous constriction. When you decrease the arteriolar constriction, this will decrease your total peripheral resistance and therefore decrease your blood pressure. Moreover, when you do not constrict your veins, you will decrease your venous return, which decreases your cardiac output, which of course decreases your blood pressure. That's why you end up with hypotension. When should I use peripheral nerve block? Anesthesia, post-operative analgesia, and for management of chronic pain. What are the freaking contraindications? If there is skin infection at the exact site that you intend to inject, bleeding or coagulation diatheses, pre-existing neuropathy before you started injecting anything.
But what if the patient complained of loss of pain sensation after I injected the local anesthetic?
Well, that's your freaking job. You did it right. That's what local anesthetics do, doofus.
What kind of agent should I use?
Geico, I'm joking. You can use any local anesthetic such as prilocaine, lidocaine, bupivacaine, mepivacaine, ropivacaine. All of these are esters or amides. They are amides because you have a prefix, I, root, suffix that has caine. More on that in the next video. Can I add epinephrine? Absolutely. You can add epinephrine because it's a vasoconstrictor, which prolongs the effect of the local anesthetic and decreases the risk of systemic toxicity.
How do I guide the injection?
Ultrasound, high resolution that is, don't be a cheap bastard, nerve stimulation techniques, and paresthesia.
Why do I add epinephrine to the local anesthetic?
This is called time synergism. Epinephrine is a vasoconstrictor. It also decreases the release of substance P, and substance P is responsible for pain. When you vasoconstrict, you will decrease the absorption of the local anesthetic into the circulation, which decreases the systemic toxicity because the anesthetic is not going to escape to far places. However, the anesthetic is gonna stay in place, keeping it localized, keeping them honest. When the anesthetic stays in place, it will have a more robust effect for a longer period of time. In addition, when you constrict the vessels, you'll decrease bleeding. So what kind of options do I have? All kinds of options. If you want to block a peripheral nerve, you can block the cervical plexus, the brachial plexus, the wrist, the intercostal nerve, femoral nerve block, lateral femoral cutaneous nerve block, obturator nerve block, saphenous nerve block, ilioinguinal and iliohypogastric blocks, sciatic nerve block, this is important, popliteal block, and even ankle block. Kiss my calcaneus. Brachial plexus block is divided into interscalene block, supraclavicular block, infraclavicular block, axillary block. At the wrist, you can block any nerve that's close by the wrist, the median, radial, or ulnar. Let's start in the beginning by the cervical plexus block, where the flip is the cervical plexus C1 through C4.
How about C5 through T1?
That's the brachial plexus, doofus. Be careful.
When should I use it?
If the surgeon wants to perform carotid endarterectomy or any procedure in this area. Where should I stick the needle?
Deep to the platysma muscle,
along the posterolateral border of the sternocleidomastoid muscle. Be careful. In peripheral nerve block, we're not trying to inject the local anesthetic into the nerve, but around the nerve. Intraneural injection is not cool. The brachial plexus has 4 approaches or techniques: intrascalene, supraclavicular, infraclavicular, and axillary. I have talked about the brachial plexus before in my anatomy playlist, but here's the basic idea. You have 5 times 5.
What is the first 5?
Roots, trunks, divisions, cords, terminal branches. For every one of these doofuses, you need to remember 5 facts. Roots, here are the 5 facts. They go from C5 to T1. So 1, 2, 3, 4, 5. How about the terminal branches? You have 5. Musculocutaneous, axillary, median, radial, ulnar. The rest of the 5s were discussed in my video called brachial plexus. Here are the 4 approaches for the brachial plexus block. Let's go. Interscalene. Where should I stick the needle? In the interscalene groove. Where the flip is this? At the level of C6. Where the flip is that? Between the anterior scalene and the middle scalene. Oh, that's why you call it interscalene. Yep, and this happens at the level of C6. What am I trying to block? Roots/trunks of the brachial plexus. Oh, more proximal than this. Yup, as you go from here to here, you're getting more distal. Clinical indications if the surgeon is performing surgery around the acromioclavicular joint. Side effects: you can hit the pleura, causing pneumothorax. You can hit the phrenic nerve, causing hemidiaphragmatic paralysis and restrictive lung disease. You can hit the recurrent laryngeal nerve, hoarseness of voice. And if the patient has a history of unilateral vocal cord paralysis, and you injure the recurrent laryngeal nerve on the other side, now both of the vocal cords are not working. This is called vocal cord dysfunction. So please take a good history. If you happen to hit the vertebral artery in the patient's neck, the patient will suffer from immediate convulsions. One of the drawbacks of this approach, it might not numb your inferior trunk. Next, supraclavicular approach. Where do you stick the needle? Above the clavicle. Well, no kidding. Where the lateral border of the sternocleidomastoid inserts onto the clavicle. What level is this? Trunk/divisions. And then indications: surgery at the elbow, forearm, or hand. Side effects are almost the same. Infraclavicular, below the clavicle, where the cords of the brachial plexus come around the axillary artery, at the level of the cords of the brachial plexus, if the surgeon is trying to perform surgery in the elbow, forearm, or hand. Side effects: you can hit the freaking axillary artery or vein and you puncture them. This is not cool. The axillary approach is in the axilla, you don't say, around the branches of the brachial plexus near the axillary artery. Why? Same reason. Be careful because you might need an extra block for the musculocutaneous nerve. So we have talked about this and this. Be careful because when you injure the phrenic nerve, it can lead to hemidiaphragmatic paralysis and restrictive lung disease. What's a restrictive lung disease? Oh, my lungs are restricted from filling. I cannot get the air in. Phrenic nerve injury, diaphragm is gone, especially on that side. So be very careful if the patient has a problem in the diaphragm in the other side, or if the patient has weak chest, elderly, weak, paralyzed, etc. When the diaphragm is gone, my diaphragm will not be able to contract and descend during inspiration, because remember, inspiration was active, unlike expiration, which was passive. Inspiration is toast. I cannot get the air in. This is the definition of restrictive lung disease, because my lungs are restricted from filling. If you do the flow volume loops, restrictive lung disease has decreased all of your volumes and capacities, and you can kiss goodbye to the peak expiratory flow rate. This is how the restrictive lung disease appear on flow volume loop, and if you remember my mnemonic, restrictive is shifted to the right. If you compare this one to this one leans more towards the right. And this is different from obstructive, which leans more towards the left. Vocal cord paralysis will give you this shape, which is diminution of both the inspiratory curve and the expiratory one, because this is vocal cord paralysis, upper airway obstruction. When the vocal cords are gone, you cannot get the air in, and of course you cannot get the air out. It's horrible. And the patient feels some kind of weird chest pain. If you want to learn more, check out my video titled Flow Volume Loop in my pulmonology playlist. The transarterial approach for the axillary block. Oh, we're actually piercing the axillary artery. These anesthesiologists are butchers. Here is how you do it. Here's your needle, filled with beautiful, amazing local anesthetics, such as lidocaine, bupivacaine, whatever cane. And then before the artery, you inject some of that good stuff. And then you pierce the artery. How do I know that I've pierced the artery? The syringe is gonna drip some blood. And then what? Continue straight ahead. Pierce the other wall of the artery and then inject some more of that local anesthetic. And then take the needle out. Because this is axillary, you might need an extra block for the musculocutaneous nerves. Now, what are the pros and cons of this barbaric procedure? The good news is you're far away from the lungs, so there is a very, very low risk of pneumothorax. That's good. On the other hand, there is an increased risk of hematoma. No kidding, I hit an artery. Intraneural injection, you can actually block inside the nerve. Intraneural is not fun. We want the injection to go around the nerve. We just want to numb the nerve for a little while. We do not want to damage the nerve forever. Moreover, systemic toxicity can happen. You know why? Because you're piercing the artery. Some of the local anesthetic might end up inside the artery, and this is the opposite of epinephrine. Epinephrine used to constrict the artery and therefore minimize the systemic side effects. However, here you can actually inject a local anesthetic inside the freaking artery, and this will take the freaking bupivacaine all over your body, increasing the systemic side effects. Intercostal nerve block. Just remember your ribs. Here is your rib. Beneath the rib, not above it, beneath it, there is the neurovascular bundle. Vein, then artery, then nerve. And the mnemonic is VAN. So I'm trying to inject a local anesthetic. Where should I inject it? Well, near the nerve. So should you go above the rib or below the rib? Of course, below the rib, because this is where the nerve is, doofus. However, in cases of tension pneumothorax, do you remember how did we treat it?
Yeah, needle thoracotomy.
And where did we stick the needle? We stick the needle above the rib because we don't want to hit the nerve. So it really depends on what your goal is. And as Dr. Stephen Covey said, begin with the end in mind. If you want to block the nerve, hit it beneath the rib. If you want to decompress the pleura, hit it above the rib. Had your woke anatomy professor told you these stories, you might have actually enjoyed anatomy. But he was actually busy enumerating the interosseous muscles. Help you. How do I treat tension pneumothorax? Needle decompression or thoracostomy tube or chest tube? Where do I put the needle? Anywhere, but usually between the second and the third rib. This is the second intercostal space, mid-clavicular line. Should I go above the rib or below the rib? Above the rib, away from the neurovascular bundle. The difference between spontaneous and tension pneumothorax was discussed before in my video titled Pneumothorax in my pulmonology playlist. So we did this, this, and this. Now let's talk about this. Sciatic nerve block. Where did the sciatic nerve originate from? It came from the lumbosacral plexus. And where's that? L4, L5, S1, 2, and 3. Sciatic nerve pain, aka sciatica, is a pain radiating to the back of the thigh and the leg and the buttock. So it goes this way. How do I block it? If you are trying to block the right sciatic nerve, let the patient lie on their left side. And then you draw an imaginary line between the posterior superior iliac spine and the greater trochanter. And then mark the midpoint of this line. And then go 5 centimeters caudal or below, inferior to that point. And this is where you inject. And that's it for today. I'm sorry I will not be able to talk about all of them because this can take an entire textbook. Pause and review. In the next video, I'll talk about local anesthetics and neuromuscular blockers. If you like this video, you will enjoy my cardiac pharmacology course on my website medicosisperfectionalis.com. I also have other courses on antibiotics, acid-base disturbances, CNS pharmacology, cancer pharmacology, etc. Thank you so much for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my courses. Thank you for watching. As always, be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.